Hi, my name is Matias Lama and I'm going to talk about Letermovir prophylaxis for cytomegalovirus infection in hematopoietic cell transplantation. Let's go with the background. Um, let's go. Well, cytomegalovirus remains the most common clinically significant infection after allogeneic hematopoietic cell transplantation. Although ganciclovir and valganciclovir are routinely used in solid organ transplantation, ganciclovir and valganciclovir prophylaxis for cytomegalovirus is limited by clinical unacceptable myelosuppression after hematopoietic cell transplantation. Thus, the development of safe and effective antiviral agents for cytomegalovirus prophylaxis remains a major goal in transplantation. Letermovir is an antiviral drug that inhibits the CMV terminase complex. So they are trying to, or in this phase 3 trial just published in the New England Journal of Medicine, they showed that this letermovir is effective for patients with allogeneic stem cell transplantation. But this patient had um, viral had a documented viral CMV in their blood. They were not CMV negative; they were CMV positive, but with not a lot of viral load. Here's a video explaining the types of transplantation of hematopoietic transplantation. Now, continuing with the methods of this study conducted, they showed that in this phase 3 double-blinded trial were randomly assigned CMV seropositive transplant recipient. As I said, they had to have CMV seropositive in their blood, 18 years of age or older in a 2:1 ratio to receive letermovir or placebo, administered orally or intravenously through week 14 after transplantation. Randomization was stratified according to the trial site and CMV disease risk. The primary endpoint was the proportion of patients among patients without detectable CMV DNA at randomization who had clinically significant CMV infection through week 24 after transplantation. So that was the main point they were trying to prove. Patients who did not have DNA of CMV at the beginning of the trial, after the administration of placebo or letermovir, how many patients had at week 24 the CMV DNA in your blood or the viral load in your blood. Patients who discontinued the trial or had missing endpoint data at week 24 were imputed as having primary endpoint events also. Patients were followed through week 48 after transplantation. Here's another video explaining what is cytomegalovirus.
Cytomegalovirus is an enveloped double-stranded linear DNA virus in the herpes virus family. It is also called human herpes virus 5. This virus can cause a variety of infections in humans, including congenital infections in infants. It is one of the TOTS infections and can cause hearing loss, seizures, and petechial rash in newborns. In adults, infection can cause mononucleosis, although 85% of mononucleosis causes are associated with Epstein-Barr virus. Symptoms of mononucleosis include fatigue that can last for several months, sore throat, lymphadenopathy, and splenomegaly. Unlike mononucleosis caused by Epstein-Barr virus, cytomegalovirus associated mononucleosis has a negative monospot test due to negative heterophil antibodies. CMV can also cause pneumonia and inflammation of the retina and esophagus in the immunosuppressed, especially in transplant recipients. Once a person becomes infected with CMV, the virus stays latent in mononuclear cells throughout his or her lifetime. Visualization of owl's eye inclusions in a cell is highly specific for cytomegalovirus infection and can aid in disease diagnosis.
Continuing, what were the results of these phase 3 trial? So from June of 2014 to March of 2016, a total of 565 patients underwent randomization and received Letermovir or placebo beginning a median of 9 days after the transplantation. Among 495 patients with undetectable CMV DNA at randomization, fewer patients in the Letermovir group than in the placebo group have clinical significant CMV infection, or were imputed as having a primary endpoint event by week 24 after transplantation. So, this means that the patients who receive Letermovir as a prophylaxis for CMV infection against the patients who receive placebo, placebo, had fewer cases of infection of cytomegalovirus, proving that the Letermovir actually works in this population of patients, as the video is going to explain here in better words.
The ideal approach would be to be able to prevent CMV reactivation, even not to make sure that we don't get any CMV reactivation, and to use a drug prophylactically. Of course, there are limitations. Like we want to make sure that those drugs are safe, they're non-toxic, they don't have significant interactions with medications that are being used for the transplant, such as calcineurin inhibitors, and don't cause the kind of cytopenias that you described. And of course, they're effective. There has been one drug recently approved, Letermovir, and I know you've had some experience with that. And could you describe Letermovir, its mechanism of action, and how it's been used?
Yeah, it's been an exciting time in the field of CMV and transplant. The Letermovir approval culminates a 10-year quest to find an agent that is suitable for prevention in the stem cell transplants. We know that in the solid organ transplants, valganciclovir is used routinely for CMV prevention. However, valganciclovir is not an option for stem cell transplants due to cytopenia. Letermovir is a very potent CMV specific antiviral that has a novel mechanism of action. It inhibits the terminase. It's an enzyme of CMV that cuts the DNA at the appropriate place as the CMV DNA is produced, and it stops CMV packaging and eventually CMV, the completion of the CMV particles. Recently, a phase 3 trial was concluded with very strong results showing that Letermovir was very effective in preventing a CMV infection when given for 14 weeks after transplant.
I know that patients can still be at risk for CMV after those 14 weeks. It's still important to monitor them after completion of Letermovir for patients who might be getting Letermovir.
So a very important manuscript with first author Dr. Marty from your institution that showed that Letermovir was extremely effective in the first 14 weeks that was given. The patients were followed subsequently through 24 weeks after transplant, so about 6 months after transplant. And we saw that a number of patients that had not developed CMV infection in the first 14 weeks, they went on to develop infection in the last part, from 3 months to 6 months after transplant. So all of these patients are routinely monitored, and so they start preemptive therapy later on.
So CMV infection, it's not just viremia that we're trying to prevent. We're obviously trying to prevent CMV disease, and I don't think in this particular manuscript there was a difference in CMV disease, but there, as I recall, there was a difference in mortality after transplant. Could you talk about that?
Yes, so CMV disease is pretty well prevented nowadays, and we have seen that in previous randomized trial, and in this trial that CMV disease at 6 months was less than 2% in the Letermovir arm and in the placebo arm, showing that preemptive therapy is very effective in preventing CMV disease. Now, always in clinical trials, patients are monitored extremely well. So in the real world, perhaps the CMV disease rate at 6 months may be a little higher than 2%. But again, the rates are low in general. What's very exciting about the Letermovir trial is that there was a difference in mortality at 24 weeks and a trend for lower mortality with Letermovir at 48 weeks. So this is the first time in a randomized control setting that we see that an agent for prevention of CMV infection has an impact on mortality.
Now, with the conclusion. In conclusion, in a diverse population of patients who had undergone hematopoietic-cell transplantation, Letermovir prophylaxis was effective in preventing clinically significant CMV infection when used through day 100 after transplantation. Letermovir was associated with only mild toxic effects, which allows for the administration before hematologic engraftment. This is very important. And was not associated with a higher rate of myelotoxic or nephrotoxic events, and was associated with a lower all-cause mortality than placebo. So let's see the final video, which talks about the uses of Letermovir in a cancer center in Texas and how they are going to implement it in their hematopoietic stem cell transplant patients.
So Letermovir is available now. It's been approved. we change our standard of care at my institution, where we're gonna start using Letermovir for prophylaxis for all allogenic stem cell transplant recipients who are recipient positive for CMV. Try to prevent this infection from the get-go. We're gonna start before engraftment, because the data showed the Letermovir had no impact on engraftment when you compare to placebo. Data engraftment was the same, has no toxicity, mainly myelotoxicity or nephrotoxicity or even liver toxicity when you compare to placebo. So it was safe enough to be used before engraftment. We're going to start at day 7 and continue up to day 100, which is the highest risk period. So this is what our center are going to start doing in the near future. And based on the data that was very encouraging from the phase 3 trial published recently in New England Journal of Medicine, I think that Letermovir should be started before engraftment. And the reason is we see sometimes early reactivation of CMV around the peri-engraftment period. It could be around day 9, day 10. That's why we made the decision at our institution to start at day 7. This way, at least, we'll cover all the cases of CMV reactivation, because you don't want to have patients who already have reactivation, then they won't be eligible for a prophylactic regimen at that time. So we decided to start it early on before the engraftment and continue this up to day 100 as the indication of Letermovir prophylaxis. Based on my involvement in the two clinical trial, the phase 2 and phase 3 trial for Letermovir, I feel confident that this is gonna be a safe drug, and as we couldn't really see any kind of signals toward for safety or for toxicity of this drug. Looking at the clinical trial, there were more patients probably under Letermovir who had a little bit more nausea or vomiting when you compare to placebo, and also numerically higher number of patients with tachycardia and some with EFib, but was mild to moderate in intensity. It didn't also lead to discontinuation of the drug. So I feel confident that it's going to be a safe drug that we can use for prophylaxis. We're not going to have much of an issue when you look at side effects. What you need to be aware of mainly is the drug-to-drug interaction. It has a long list of drug-to-drug interaction, and we have to be monitoring this impact or this kind of interactions as we go. When we put patient on prophylaxis with Letermovir, we may have to check level of immunosuppressant like tacrolimus or cyclosporin, and also level of probably antifungal therapy like voriconazole mainly. So we may have to do a little bit more vigilant, to be more vigilant in order to look for any kind of adverse event related to the drug-to-drug interaction. So we're going to learn more and more as soon as we start using it, but something that we need to keep in mind, at least in our group, in our institution, I feel very confident we have a very strong clinical pharmacist on our team. Our pharmacies are very helpful to keep a track of that and to warn us or try to adjust if need be for these drug-to-drug interactions.
Thank you so much for your attention.